Every step is an improvement, and that's what we're really working towards, because it's not um, a simple sprint that we're running, but a marathon. And so with that being said, each of these panelists that we have today, they are also working in their own respective fields, doing the work that they do and also organizing as well. But let's go ahead and start with um, Sarah. If, oh, whoops, I skipped a name. But let's go ahead and start with Sarah first, and then we'll go in random order. Sarah, please introduce yourself.
Thanks, David. My name is Sarah Christofferson. I am the Policy Advocacy Director for the National Women's Health Network, and we're a national nonprofit based in DC. So for me, it's 9 o'clock at night. If you see me sneak a yawn, that's why. We work on expanding access to healthcare. We've been very involved in the big fights about getting the ACA implemented, getting the ACA expanded through the recent COVID relief package. And then prior to joining the network, I spent 10 years working for members of Congress as a legislative director. So I was actually on the Hill during the big fights around the ACA. So that's a little bit about me. David, back to you.
Thank you, Sarah. You're very good at that. Athene Dar, we'll go ahead and hear from you. Please introduce yourself.
Hey, sure thing. Thanks, David. My name is Athene. I'm an assistant professor here in the University of Pennsylvania, Philadelphia, so not that far from Sarah, and also may yawn occasionally as it gets closer to 10:30 Eastern time. I'm an internal medicine physician. I see patients over at Penn Presbyterian in West Philadelphia and was on the front lines for COVID towards the beginning of the pandemic. And the other thing that I do is I'm a health economics researcher, and I'm very interested in the social, economic, and structural forces that shape people's health behaviors and health. I spend a lot of time in the ivory tower. It's not often a very practical place. And so I'm very excited to be on this panel to see how we can translate those ideas into policy.
Great, thank you so much, Athene. See what I told you? It's going to be a great panel already. Okay, next, and then last but not least, we have Liam. Go ahead and introduce yourself, Liam.
Hi, so I'm Liam O'Mara, and I'm going to ramble a minute longer or so than everybody else here because, well, I'm stuck in politics and I have to say a little bit about myself here since we're going to be talking about healthcare the whole night. So I'm Liam O'Mara. I'm the Democratic candidate for the 42nd in Southwest Riverside County, and I'm a professor of history focused on the history of ideas. And I came to that by kind of a long, winding road. No one in my family had ever done a college degree, and I didn't start till age 30. But powered on through to a PhD, and now more or less have my dream job, teaching folks in college, to reach for the stars. But those stars are receding. It's getting harder and harder to get ahead. My generation, Gen X, is the first one in American history not to do as well as the one before. And the generations after me are considerably worse off. We've abandoned the lessons that we learned in the Great Depression and Great Society decades. And I got into politics because I'm tired of explaining to my students why they're pretty much screwed and why we are dooming them to inherit a country with growing poverty, exploding debt, shrinking opportunities, and the like. The challenge for me, and one of the reasons healthcare gets particularly interesting, is that we have to frame the kind of policies that used to be mainstream and drove 9 presidencies in a row from 32 to 72, but which have really fallen out of favor. And I have to try and explain to people that neoliberalism and conservatism both did this, and that we can't scapegoat or deflect our way out of it. We got to, pull up our boots, take some responsibility, and get to work. So given healthcare is a big issue in this country and in my campaign, I'm really happy to join the California Yang Gang. Great to see David again as well, and talk about what we can do about this.
Great, thank you so much, Liam. Great to see you as well. I do not envy you running for Congress because I kind of have a personal life now, but but I give you all power and support. For those who are just tuning in, this is a healthcare policy panel, How to Humanize Healthcare, hosted by California Yang Gang. My name is David Kim, and I'm your moderator for the night. Before we begin, just a reminder to the panel of speakers, if you have any assumed knowledge, please try to share that so our audience can be completely present and not have to look up stuff. If not, I'll go ahead and ask you questions. And then also just keep in mind the length of your answers, try to be concise, but then also don't cut yourself off. Explain and be thorough as much as you want to be as well. So with that being said, for those who are looking for this discussion to be about single payer only, this is not that type of discussion or panel. It's going to be about healthcare in all different aspects, currently, forward, the issues and whatnot. And so the what we'll start off with is the current healthcare system. I think if I were to pose the question to all of you guys and you unmuted yourself, and asked you this question, you would probably be able to answer it nonstop. But what are the current issues that we have, the problems that we have in our healthcare system? I can go off naming them as well. And that's why Medicare for All and single payer was part of our platform when I ran. But this is a question for each panelist. And this is what we'll start off with. This time, we'll start off with Liam, who just finished sharing. What is the single most glaring issue in US health and healthcare policy right now?
I would say that I object most to the for-profit nature of healthcare. And by this, I don't mean the money that goes to providers. Everyone deserves to get paid, but what goes to corporate shareholders. Because prior to the Nixon administration, profit was held out of the healthcare industry in that sense. But since that change, prices have been skyrocketing for Americans and going up faster and farther in the US than anywhere else in the world. We're currently paying twice as much as anyone else, and we still don't even cover everyone. And I think it's well past time that we accept that mistake and reverse course on it. I mean, that's my biggest one.
Great, thank you. We'll go to Athene next. Athene? We'll go to you next. What is
sorry about that.
Oh no, you're good. What is the single most glaring issue in US health and healthcare policy right now?
I think the single most glaring issue is that average life expectancy in the United States has been falling since 2014. And that was before the COVID-19 pandemic. That is a shocking number, because that has not happened in any of our histories. I mean, we have had this secular increase in life expectancy for a really long time. And that worsening health has really affected people without a college degree, people who have lower incomes. And that is an incredible divergence in American society too, which also, I think, follows with income inequality and also falling economic opportunities for many people. And so I think those trends are linked. And the healthcare system, the way we're investing in it, the way we've increased our spending in that since 1980, that has not translated into improvements in actual health for many Americans. And that divergence, the way we think about health and healthcare and what we're investing in, I think is a massive problem.
Thank you. Oh my gosh. I know I'm a moderator, and I'm not supposed to chip in, but oh my gosh, yes, we spend the most per capita in healthcare, and it's crazy. And you're all nailing it. Sarah, next, what is the single most glaring issue in US healthcare and health policy right now?
Well, I think you're definitely welcome to jump in. So that's your moderator's privilege right there, is you get to jump in whenever you want. So that's great. You know, I sort of echo a little bit what Liam said. We may come to it a different way though, which is that on the one hand, there's all these glaring gaps in coverage. And then there's this sort of related issue of even the folks who have coverage don't always get to use their coverage, right? Whether they're going to providers who don't take their coverage, right? You know, the one that comes to mind, top of mind for me recently, is trying to find a mental health care provider anywhere in my area who would accept health insurance, right? It's extremely difficult to do. So getting that first leap of getting everybody covered with high quality, affordable care. Now, I might disagree with Liam because I can envision a role for a for-profit, a for-profit structure in there. But regardless, getting everybody to universal coverage and then making sure that they can actually translate that coverage into the actual healthcare that, you know, it's not insurance that makes you better, it's healthcare that makes you better. So that is sort of, they're related, but it's a big problem that we have to tackle.
Yes. Oh, I thought I was muted. Yes. With that being said, given you've each shared what really stood out to you to be one of the main issues that our leaders could be focusing on and really putting their energy towards. With that being said, what are the ways to do that? What are the three top things you'd fix with the current system? It doesn't have to be directly in relation to the glaring issue you pointed out. It could be touching upon other areas as well. But what are the three top things you'd fix with the current system? This time we'll go ahead and start with Sarah.
So of the two big things, you said you gave me the freedom to not tie it back to my big glaring problem, but I'm going to do that anyway.
That's fine.
And of the sort of two corollary problems that I mentioned, to me, the easiest one to fix, the one sort of that I focus on, is coverage, right? Because there are so many things that we could do, even by the constraints of our current political system, to increase coverage. And partly we've done a little bit of that through the COVID relief package. We don't need to go into all of that right now, but that built on the existing Affordable Care Act in a way that could actually get 5 million people additional coverage. So there are little things here and there we can do to get to coverage.
Okay, great.
Now I don't what I was saying. To get to coverage. So that is sort of where I focus, is how do we solve those problems? How do we solve problems for immigrant care, right? In the United States, if you're not eligible for public health insurance if you don't have documentation status. You may be able to get private health insurance, but you're not eligible for public health insurance. If you're a lawfully present immigrant, you need to wait 5 years. How do we fix those kinds of coverage questions? That's what I'm kind of working on a daily basis.
Thank you, Sarah. I'd be curious to talk also, I know that you had just shared earlier that you think a for-profit model is possible, and I'd love to talk about that more, how that relates into the motives of dollars and money being spent into research on adverse selection and all of that with the current system and how that plays out. But yes, thank you so much for sharing that. Athene, what are the three top things you'd fix with the current system?
Sure thing. So the first thing I would do is think beyond healthcare. So healthcare is important. I mean, I'm saying this as a doctor, but when I discharge patients, I'm discharging them back to the very lives that made them sick in the first place. We have incredible economic precarity. We have widening economic inequality. We have people who don't have hope for the future. These are all things that social policy can actually fix. And you have data that shows that things like the child tax credit, minimum wage increases, expansions of the EITC can actually save lives throughout the life course. So integrating what we think of as health, as policies to improve health, will involve broadening our focus beyond hospitals and clinics and even insurance. The second thing I would do is we really need to do a lot better with mental health. Even with some of the reforms in the early 2000s, and with now more recently trying to expand access to medication-assisted therapy for things like opioid overdose disorder, we just do a terrible job. There are few psychiatrists, there are few therapists, especially in rural areas. The access is not there, but there's a ton of trauma that Americans face. The third thing I would do is make sure that everyone does have access to a good, high-quality health insurance plan. And I know there are lots of different ways. You mentioned some of them: single payer, Medicare for all. And I think we can talk about later what the trade-offs of those different things are. But I think ensuring that everyone can at least get a reasonably high standard of healthcare in America is an important thing to do in the healthcare system.
Thank you, Athene. I completely agree. Liam, what are the three top things you'd fix with the current system?
Okay, so cheating again and setting aside that first one, because I do have serious issues with the way we structure insurance in the US and just how badly regulated it is. Oh boy. Athene hit a really important one for me that I talk a lot about in the campaign, because I talk a lot about it in the classrooms too, and that is the actual impact of income and wealth inequality in this country. And we are just, I mean, if you look at the lifespan disparities, yes, as a whole, the country is actually, our lifespans are falling, but not for well-off white folks. It's much, much worse for people, for minorities, for African Americans in this country. And that's largely a consequence of poverty. If you look back to the 1960s, when people like MLK were demanding that we actually address the racial wealth gap, the gap was about 4-1. And today it's about 10-1. We have gone in the opposite direction. And that's a real problem with real consequences. And it affects tons of other areas. So many of our problems today ultimately relate back to our economic policy. In terms of much more healthcare specific issues, obviously, and this kind of relates to the whole theme of this discussion today, we need universal healthcare. We absolutely do. I mean, there are a number of reasons that the U.S. is by far the worst in the rich world in the way we've handled this pandemic, but this is one of them. I mean, we simply do not have the care there. And there are so many people that have no options. They have no place to go. Athene also mentioned the issues with rural provision. I mean, my fiance was from Northern New York, and it's, when you have a small town there, it's very difficult to attract providers to it in the first place. You're often stuck driving 100 miles just to get basic health care. Right? And we can definitely do better in so many of these areas. And as a simple one, as a third one, I really have an issue with pharmaceutical advertising, which just isn't done anywhere else in the world. If you need some kind of treatment, your physician should be providing options to you. We shouldn't have lobbyists walking in trying to convince the providers to prescribe things and then putting stuff on television. So we walk in saying, "Hi, can I have drug X?" It blows my mind. One of the reasons we also pay far more for prescriptions too, but whatever. We'll talk about that stuff later.
Thank you so much, Liam. And for our panelists, if there's something that you wanted to add upon in terms of a previous answer that was just shared by a panelist, be it concurring or disagreeing, feel free to do it when you're responding to other questions, weave it in, so that way we can get some more varied views on that. And we're all really here to share our views on what we think is the best approach to going ahead and doing it. And that's not a right or a wrong thing. We're just coming with different perspectives and experiences in that. Given that, now, I mean, we obviously kind of know what areas do need improvement. Are there any areas that are currently working, that are functional? So if you could, we'll start with Athene. Tell us what you think based on your experience, and each of you have different perspectives and experience. Based on your experience, what are some of the most functional and dysfunctional parts of the current healthcare system? Since we've spent already some time on inferring and referencing and directly stating what the dysfunctional parts are, what are some functional ones, if any?
I think there are a couple things. So the first thing is, for Americans who have insurance, they love it for the most part, especially those who are in Medicare Advantage plans. So if you look at Medicare, there's a lot of satisfaction. Medicare Advantage plans kind of compete against each other, and there seems to be a reasonable amount of satisfaction around that. I'm not saying it's perfect, but it's pretty good. The second thing that I think is really good about the US healthcare system is that the level of innovation that we have in the United States is incredible. So if you look at, as a function of our GDP, how much we spend on pharmaceutical research, it is way higher than a country like Australia, whose GDP is comparable, but their expenditures on pharmaceutical research is much, much less. And granted, there may be some distortions in the pharmaceutical market and the profit sector. But the fact is, the innovation that the United States drives actually subsidizes health innovation for the rest of the world. That's one of the reasons we spend more on healthcare, period. So we have some satisfaction with quality insurance plans. We're an engine of innovation that subsidizes innovation for the rest of the world. And I think in pockets, we have competition that allows for, I mean, in some ways it can get deranged. And I think Liam and others are really going to talk about that. But there are other aspects of it that are positive. So we know that the NHS in the UK actually adopted a US style patient choice piece in their health system, which is obviously a nationalized one. And what they found was mortality actually dropped because now people were competing for patients on the margin of good quality. So there are things I think in the healthcare system that we want to keep. And I'm speaking specifically about healthcare here. And so as we think about reform, we have to think about how the changes we're going to make, how are they going to trade off with some of the stuff that we already do really, really well. The other thing I'll say is Medicaid is awesome. Where it's been expanded, we've seen that people's financial security improves, they're less likely to be in debt, and multiple studies have now shown that it saves lives, and that for kids who are exposed to Medicaid early in life, they grow up to be healthier and more productive adults. So I'll stop there.
Thank you, Athene. We'll go ahead and have Liam answer next. Liam, feel free to, you don't have to, don't feel forced to, but feel free to tell us what you think are some of the most functional and dysfunctional parts, if you want to, of the current healthcare system. And for those that are kind of functional, how do we go ahead and maintain that continues to take place despite what changes and policy pushes happen?
Yeah, I think from their vantage points, both Sarah and Athene are going to have more positive things to say than I will, largely because I mean I deal with things more in terms of like the economics and public policy stuff. And if you compare the U.S. internationally, I mean, I hate to be a negative Nancy about this, but my answer is kind of easy. There's not much we do right from my perspective in healthcare. I mean, it's not for nothing that we're ranked 35th in the world, that we're in 36th place in terms of child wellness and preventing infant mortality, which is like, are you kidding me? I mean, we've already mentioned the falling lifespans in this country. I mean, given that we spend more and we are by far the richest country in the world, to be scraping the bottom of the barrel in almost every area really, really bothers me. Now, it is true, as Athene said, that we do drive a lot of innovation, and there is a lot of significant medical and biotech research in the US. But it's not like we're the only place this stuff happens to, and I don't think it makes up for all the other liabilities. I don't think it makes up for leaving tens of millions without insurance or underinsured. I mean, we don't even produce enough physicians to meet demand in this country because it's so ungodly expensive to go to medical school. I mean, there's just so many areas that we really struggle in. I mean, like I said, I think that they'll have some more positive things to say, but I think that in almost every possible area, we can definitely make improvements, and I think that that's something that we used to really excel at in this country, was always trying to do better, to step up our game, so to speak. And I really want to see us do that.
Thank you so much, Liam. Sarah, what's working the best? What's really not working? And do you agree with Liam?
So the one place I might push back and Liam sort of, that we're not doing anything right is, and take this for what it's worth, we're blowing Europe out of the water when it comes to vaccine distribution. Out of the water. Like, they are absolutely eating our dust in terms of vaccine distribution. And I'm not sure I could tell you why. And I'm not sure I could point to this or that component of our healthcare system to say this is the reason. But there are examples like that. If I'm going to be the devil's advocate to that, there are examples like that where if you're going to get a vaccine, I'm glad to be sitting in the United States right now. But the example I was going to use myself was Medicaid, because not only are, everything that Athene talked about, it's hugely popular, right? And you see that even in the States. Let me back up just a tiny little bit. Can I explain something about Medicaid? Can I take a little bit?
Please.
So people hear Medicaid and they think poor people, right? They think low income, that it's the program, sort of almost a universal program for low income folks. And in fact, that's not the case. It's original Medicaid has always been low income, and it's a categorical eligibility program. So to qualify for original Medicaid, you needed to be low income and pregnant. And then in some cases, 60 days after you weren't pregnant anymore, you didn't qualify for it. So, and there's a whole host of others, low income and with a disability, low income and a senior. One of the things the Affordable Care Act did was expand Medicaid. So we talk about Medicaid expansion to everyone who fell below a certain threshold, an income threshold. So you didn't have to, if you were 61 days postpartum, you still got to keep your coverage. And that was a tremendous expansion in terms of equity, right? Reaching people who had never been captured or never been captured for long in state Medicaid programs. Now, the Supreme Court came along in 2012 and screwed us all slightly by making it optional. The law had made it expanded to everybody. The Supreme Court ruled that that mandatory expansion was unconstitutional and that it was up to states to voluntarily opt in. I see Liam shaking his head no, but I'm right, so I'm going to ignore that. So what you see now, though, is in those states that did expand Medicaid, they are getting all of that benefit that Athene just talked about, where literally right next door, in some cases, you have those non-expansion states where those people don't have access to any coverage. They're not covered by the, oh, okay, great, thanks, Liam. They're not covered by the Affordable Care Act's subsidies to help people buy private health insurance, and they're not covered by Medicaid expansion just because they happen to live on the wrong side of a border, right? And so what it shows, though, when you look at it's terrible, but it's a perfect case study for us because we can now compare the people who've had access to this program to the people who don't have access to this program. And you really do see that the people who've had access are flourishing, right? It actually does make a real difference in their lives to have this benefit. So that's one good thing, positive.
No, thank you so much for sharing that. Some people are still trying to understand how the different programs work. So thank you for doing that. I mean, based on your answers so far, the three of you, the common words and underlying opinions seem to be, we need higher quality care. We need more affordable. We need more access and coverage. We need universality. And so before we get to that and discuss how we do that and what are the different options and models we can look at, what are the biggest barriers to implementing fixes? And we'll start off with Liam.
This is an easy one for me. Lobbying and political corruption. I mean, our healthcare system is at the bottom of the rich world because we allow these for-profit enterprises to effectively to bribe officials into passing rules and legislation that transparently favor their bottom line and shareholder interests and not, public interests and public health. And I think that until we address the underlying corruption, until we address the question of lobbying, that almost any reform that we manage to pass into law is going to be perverted somehow in the same way that they have continually watered things down. And actually, the SCOTUS decision, I was actually agreeing with Sarah there. I mean, we've had a lot of really bad decisions that negatively impact us. And it's not without reason that we pay twice as much. It's by design because we allow these companies effectively to buy members of Congress. And I think unless we solve that, we're ultimately going to keep dancing around this issue and have to keep coming back to it over and over again because people will slip in little riders, little pieces on different legislation to slowly destroy any reforms we put into place.
Thank you, Liam. I'm going to save Sarah for last. Let's go, Athene. What are the biggest barriers to implementing fixes? Be it fixes you think should happen or any of what your other panelists should.
So if we start with healthcare just as a healthcare industry, I think it's very large, it's very complicated. It's a system that has evolved over many, many decades, right, in some kind of piecemeal way. There are many, many stakeholders. It is now one of the, if not the largest employer of people. It's the fastest growing industry for folks without a college degree. So there's a lot of stake in the system. There's a lot of jobs, there's a lot of money. And so moving in the context of a system like that is tough. So I'd say that's the first thing. These are just the realities of building consensus when people have skin in the game. The second thing is, I think change is a lot harder than people realize. So one of the big, I'll just give you an example. One of the big popular ideas that we tried to implement in healthcare was cost sharing with high deductible health plans or something like this. And the idea was if we had patients have skin in the game, it would mean that they would make better decisions, and they would spend less on low value things. Things that, like I would do that are not going to really improve your health, but cost a lot of money. So that's the waste part. But it turns out that actually that really didn't work. So we had people get in these high deductible health plans, and they did spend less on low value things, but they also spend less on things that are actually good for them. And so trying to get a signal for improving quality is really, really hard. And so these are questions that, there's lots of different things that have been tried. There's unintended consequences, there's side effects, and that whole picture of putting it together it's just not an easy problem, and it requires kind of deliberate experimentation and effort. The third thing is, I think there are forces outside the healthcare system that have, made people sick, that the healthcare system is increasingly has been less able to tackle. So in the work that I do, I look at how people's economic opportunities influence their health. And in one study, I looked at an industry that's kind of game for job loss because of automation, the automotive industry. And what we found is that where plants closed, there was this huge increase in opioid deaths. Now that's something that is outside the purview of a healthcare system. At the time, we did not have the tools to kind of get into those communities and actually save those lives by getting people onto medication-assisted therapy. And the structural forces that are driving people's health are outside what I can do as a doctor. And so we have this reconciliation where what is affecting health and what healthcare can do are increasingly kind of diverging. So I would say those are three challenges. There are many, but I think those are three barriers that we've faced.
Thank you, Athene. I think all of you are just, as each of you are sharing, it's like, oh, yep, that's a barrier. Yep, that's a barrier. And even in the chat, I know Davis, he talked about decoupling insurance from employers. Like, why is it that we have, because of the cost of healthcare going up, now employers are trying to save. And so they're kind of trying to save in all aspects. And that's why we have high deductibles. We can go on and how that hurts, whether it be with small businesses who are required to provide over a certain number, or whether it be trapping people in their jobs, because if they leave, otherwise they won't have healthcare, or from starting and creating new jobs, or starting on their own thing, or spending time with their families. And so just in all respects, I feel like kind of going back, and maybe we can have Sarah comment on it. For my personal opinion is the whole for-profit structure, because immediately I saw somebody in the chat talk about pharmaceuticals. And politicians, I just remembered doing research last campaign cycle, and I saw all of the pharmaceutical donors to my opponent. And I'm just like, one of his biggest donors is, I forgot the name of the pharmaceutical company, but it's really strong on kidney prescriptions. And they filed a patent suit against a Swiss manufacturer, even though they had a cheaper and more effective drug from coming in. And so with all of that, it's sort of like connected in a way. And yes, there's other risks and plus and minuses to consider. It's not just kind of black or white per se, but if from a macro level, it kind of is in a way. But given that, that's my added part, as if I'm the fourth panelist. But Sarah, what are the biggest barriers to implementing fixes? And we'll move on to the next section.
Well, now you've given me a lot to work with, but I'll start with what I had planned to say, and we'll sort of circle back around, which is that the first couple of things that Liam and Athene said were the flip side of the same coin. So Liam talked about lobbyists, Athene talked about stakeholders, and those are in some ways the same people, right? So when I go to the Hill and I am lobbying on an issue like expanding the ACA or expanding health insurance, that's good lobbying, I'm great. And everybody who opposes me, those are the bad guys that no one should listen to, right? So every pharmaceutical company has patient groups of people that they bring to the Hill who really do benefit from whatever XYZ drug or whatever XYZ therapy. And so it's very difficult to say these are the lobbyists versus these are the stakeholders. They're really sort of the same people. And it's they're constituents too, right? So some of it is money in politics, some of it, but also it's listening to the biggest employer in your district, or listening to very vocal patient groups. And that really does just make it difficult, right? So there's a reason why the Affordable Care Act tackled, it's a massive rewrite of the healthcare system, and it didn't touch prescription drugs almost at all, because there was just no political will to take on all of this and all of that, right? It was just a massive undertaking. But the other thing I wanted to talk about, because I just see it all the time, is the right-wing echo chamber, right? So, having spent a decade on the Hill and having answered all of those angry constituent calls and having lived through that whole era of get your government hands off my Medicare, right? Where, you're imposing death panels on us. I mean, just, the unbelievable things that people really believe, and those people are motivated and they're active and they're voters and they storm town halls. That has an influence, right? That really does have a big impact. And the amount of just flat out misinformation that just pummels people every day, and whether it's Fox or ON or Newsmax or Sinclair coming to you through your local TV station, it's just like drinking from a fire hose of misinformation. And then it makes it very difficult to, so for those of us who backed the ACA, I personally would have, my own personal philosophy would have been a much more aggressive government approach towards ACA or towards healthcare. But here we were passing what is a market-based, relatively conservative plan, and just being told, blasted, people coming into our office behaving violently, that there was socialized medicine, it's just totally unhinged from reality. It's very difficult to get anything done in a democracy if 40% of the population is in a totally different reality than the other 60%, because the other 60% has fact-based, legitimate differences of how we get to a certain place. So while we're all here having our fact-based disagreements about stakeholders and how much regulation and how much this and that, there's a whole other group that's convinced that Democrats drink the blood of children, right? I mean, that's sort of, I don't know how we solve that problem, but that's what I think about all the time.
That's another barrier for sure. With that being said, given the realities that we have that we can't ignore, because we can't just ignore realities and of whatnot. And so given, be it the example of the right-wing echo chamber that you provided, given that, what are the best examples or model examples of healthcare systems in the world to look at? And are those feasible to some degree here, given the realities that we have? And if so, how does that work? How is it already working? And you can draw comparisons to what we already have, be it Medicaid or are fighting for single payer or ACA expansion. So with that, so I'll go back to that question. What are some of the best models and systems of healthcare in the world right now that you think would be feasible here, given our realities? And feel free to touch upon, in comparison or contrast, our current policies here. We'll go ahead and start off with Athene on this one, and then we'll go Liam and then Sarah.
So just to clarify, you want to do a comparative of the different healthcare systems?
Yeah, what are the top healthcare systems, or what are healthcare systems that you found yourself referring to a lot and kind of having the thought of, oh, that would be great to model here. And is it even feasible here? And what does that look like?
Yeah, so one thing I might do here is I want to answer that question, but I know Sarah teaches a comparative health systems course and looks like she's chomping at the bit for this.
Okay,
do you want to take this first, Sarah, and then I can just jump in right after you?
Well, how about I'll just give a very quick level set, just so that we're all sort of on the same page.
Oh, that's right. Sarah, you teach. Okay, yes, you teach this. Go ahead. You start off first. Bad moderator.
But so I want to just say that I want to give a very quick 10,000 foot level and that it's a little bit like your teacher told you can't subtract a bigger number from a smaller number, and then you later find out you can. I'm going to speak in some generalities, which, so just so that we're all on the same page about different kinds of systems. So the first, there's sort of like three big kinds of systems. And actually we have all three types in the United States. So in addition to some international examples that the panelists will talk about what's working well other places, we actually have examples in the US. So first big bucket, sometimes it's called socialized healthcare, but the government pays for the healthcare and also employs the providers and owns the hospitals and clinics. So the government is sort of like a full package, right? And so a really famous international example would be the National Health Service in Great Britain. But we have examples in the United States. So Department of Defense, Veteran Affairs, Indian Health Services, where you walk in, you are eligible to go into there because you qualify for VA status or Indian Health Service status, et cetera. And you get the sort of full course government treatment in a government hospital by a government provider. So that's that first big bucket. Then the next kind of big bucket is what's often referred to as single payer, which is where the doctors, the clinics, the hospitals are all private. They're not owned or operated by the government, but the government pays the health insurance, right? So an international model would be Canada. The Canadians are going to pipe up and say they also have private health insurance, but let's just big picture, one international model would be Canadian Medicare. But we also have examples in the United States. We've talked about them a little bit already: Medicaid, Medicare, TRICARE for military personnel. So you're still going to see a private doctor and a private hospital, but you're using your government paid health insurance. And there are certain limitations that we've talked a little bit about what that looks like. So we've mentioned no undocumented immigrants. We've mentioned a waiting period for lawfully present immigrants. Federal health insurance programs don't cover abortion care. There are a handful of things like that. There's these sort of carve outs where certain kinds of people or certain types of services aren't covered. And then the last big kind of bucket is what's often called like sort of a multi-payer system. And the easiest way to talk about this, to think about this, is that it's all private, and it can be for profit or it can be not for profit, or it can be a mixture of the two. But you've got private health insurance companies paying for services to private providers, private doctors, private clinicians, private hospitals. And so if you have health insurance through your employer and you're not a federal employee, you've got that kind of private to private model. There's one of the famous international examples is Switzerland. Switzerland actually served kind of as a model for part of the Affordable Care Act, the way the Affordable Care Act is structured. And we also in the US, so in addition to the employer market, that's also how what they call the individual market is, which is where you're going out and buying health insurance on your own from a private employer. So that was me wanting to just kind of get us in the same page about the three different kind of buckets, if you will. And then I'll kick it back to everybody else.
All right, so let's kick it back to Athene.
Sure thing. I mean, I think the health economists often ruin these discussions by pointing out what you can and can't have. It's usually the can't part. I guess what I can say is across those typologies, this is really a question of values. So, depending on what country of the world you look at, there's strengths in different bands. So if you want to choose your doctor or hospital, like Germany or Switzerland are, potentially really good options. If we care more as a society about what we pay out of pocket in terms of a copay or something, then Canada or the UK are interesting systems to look at. And if we want drug prices to be low, Australia, for example, does a really good job of that. So I think every part of the world or every country in the world has a health system which has different advantages and disadvantages. I talked about maybe some of the advantages of ours early on, and I accept Liam's point that some of the trade-offs we're making as far as coverage may not be, I think, as a society, what we would want. So what can we do going from here forward? I think if we take the US system and kind of all the inertia that's in there and all the strengths and all the weaknesses, an attainable standard might be something like what the Netherlands has, where it's basically everybody is kind of in a plan that's a little bit like Medicare Advantage, right? Like people like it, um, so it's a private insurer, but like in this case, it doesn't have to be private. It can basically be within Medicare kind of competition, run by a private organization, government funded potentially. People get to choose their doctor, and then it's that primary care workforce kind of gatekeeps their forward. So that's possibly one direction that we could go. I think that ultimately, I don't have a specific horse in the race other than getting people covered, because I think that's important, and potentially reducing this dependence with employer-sponsored insurance, because I think that's inefficient. But ultimately, whatever we choose as a society, we have to be honest about what we're getting and what we might be giving up that we like. Something that may be hard in a society like ours, where it's so diverse and disparate, and there's a high degree of income inequality, is something like a single payer plan where there's one plan for everybody. Like, I think inevitably that's going to make someone worse off from where we are now. And so just keeping that in mind, I think will clarify the rest of the conversation. And I think I really like the structure that Sarah gave, and kind of how you think about this. Each of those bins has strengths and weaknesses.
Leah, thank you so much, Athene. Liam, in regards to what Athene just shared, do you agree? Do you somewhat with the Netherlands model approach, and that being something that we could be moving towards? And then any other comments, or feel free to share anything else.
Yeah, there's a few things specifically in Athene's comments that I agree with and I want to come back to. The first thing I want to just at least clarify, or what might be confusing, is that the multi-payer system in other countries does have some kind of mandate in place that makes sure everyone is covered. We have a multi-payer system overall in the US, but we do not require that everyone be covered, and we do not subsidize people who can't afford to buy it privately. So that leaves us as the only advanced democracy without universal health care. One thing that I kind of agree with, and this is, I think it said I have no skin in the game. I can't quite say that, because I am publicly for single payer as an interesting midway point between the three models. But as far as I'm concerned personally, I wouldn't care which of the three we ended up with, whether it was, something like the NHS and everyone was covered, or a single payer system and we just replaced the insurance sector, but providers are all private enterprises, or it's all private enterprises, but we have something like the German or Swiss oversight model, where we have effective regulation of the insurance market so people aren't being gouged like they are in the US, and we actually make sure that everyone is covered. So we step in when somebody can't afford to get that insurance so that everyone gets it. At the end of the day, it doesn't matter to me which one we end up with, as long as we actually have effective universal health care. And I really want to stress effective, because just having a policy, I don't know, some of you may have personal experience with this. I know I do. Just having an insurance policy does not mean you get good care. It doesn't stop you from getting stuck with massive bills at the end of the day, or someone saying, gosh, that test is really expensive. I don't think we care enough about your problem to bother trying to solve it for you, and just turn you down. That happens constantly in the US. And that to me is intolerable. Whatever system we put in place needs to make sure that people get health care, period.
Thank you, Liam. Last but not least, obviously, is Sarah. Sarah, feel free to contribute, comment on what Liam or Athene shared, or what you wanted to build upon from earlier as well.
So I sort of don't have it. I have a personal bias in that I am sort of ideologically, philosophically inclined towards a single payer system for the efficiencies it brings. But I do think we should be realistic that those kinds of cost-cutting decisions sort of happen everywhere. Sometimes they're made by, in private insurance companies, and sometimes they're made by government officials. And, maybe there could be an argument to be made that government officials have more accountability in a democracy, and so that makes it inherently better. But some of those decisions about, what what test is going to be covered. You know, those kinds of cost cutting decisions are being made kind of everywhere, might be my one rejoinder. But, you know, I'm a little, I think it's unlikely that we would move to a single payer system anytime soon, certainly not in the kind of timing that was discussed maybe during the presidential campaign. But there are actually all kinds of really interesting sort of partial proposals that could get us closer to the question of universal coverage, closer to solving these issues around job lock. And, you know, I'm not going to speak for the economists, but one of the things that I think about in terms of the job lock all the time is I would love to start my own business, right? I would love to bring that entrepreneurial spirit to, there is no way in hell that me and my 3 children are leaving the safety of my employer provided health insurance right now, right? So there are all these sort of spillover effects that our current system builds in that have these, you know, economic consequences for us. But I get excited when I think about things like Medicaid buy-in, right? We've talked about how well Medicaid works. We've talked about how popular it is. You could potentially give people the option to pay a premium and get into that Medicaid coverage. We've talked about lowering the Medicare age. So if Medicare is for seniors over 65, you know, the thing about Medicare is for the 65-year-olds in Medicare, those are the young, cheap, inexpensive people in Medicare, right? The frisky 65-year-olds. But when you're looking at the broader health insurance program, maybe the employer provided insurance, those 65-year-olds, those are the old sick people. So if you were to lower the Medicare age, maybe to 55, and again, stakeholders are one of the reasons why that might be a challenge, but it's one of these things out here. If you were to lower Medicare enrollment to 55, you would fix job lock for a lot of older folks, but you would also make Medicare less expensive and simultaneously make private health insurance less expensive. Because for the private health insurance model, those 55-year-olds, they're old and expensive, but for Medicare, they're cheap and young and healthy. And so there are things like that that get very wonky, but this is the policy nerd night, right? So I'm okay to get a little wonky. But there are things like that that could move us sort of closer and closer to where, you know, I think we want to be, but without generating the sort of massive freak out that some more urgent proposals or, you know, speedier proposals would generate. Because when it comes to people's health care, man, they might hate their private health insurance company, hate them, but they sure as hell don't want to lose it, right? So we're dealing with that loss aversion principle. I don't want to risk what I've got, even if there's a potential for something better. And so I like these incremental approaches. But I can see folks unmuting, so I'll.
Thank you. No, Athene, were you going to add to that? Did you unmute? No,
I did, and I just wanted to say I really like. I mean, the incremental doesn't have to mean not transformational, and I think, you know, what Sarah outlined would be, I think, have impressive kind of equilibrium effects on market prices. The other thing we could do is make the exchanges more national, and pour in more subsidies so that people could participate in the exchanges and buy different plans. And I think that also can improve efficiencies as well. So there are lots of these things on the table that maybe were left on the table at the time the ACA was negotiated, but potentially could be picked back up from those remains. And so I think these are really important points.
Yeah, I think with the different, I mean, various health inequalities that we currently have, looking at what those are, identifying that and discussing that more, and then seeing what policies are driving that can be a start from where we go in terms of that incremental approach. And it's not for those who are strong. I'm a strong advocate of single payer. It's not giving up on that, but it's also understanding the reality of that right-wing echo chamber of these various things. But then also, is that all possible though to do at the same time too? if we really want to. Again, I'm not trying to play the devil's advocate, but Liam, did you have any thoughts on that? And then we'll go ahead and close out this part and go on into the next part.
Yeah, just a few things that I can add to. I like that Sarah brought up the question of lowering the Medicare age. It's worth noting that when Medicare was initially rolled out, the intent was to steadily lower that and cover everyone, and they just stopped. It just 50 years later, we're still twiddling our thumbs and waiting for more of it to spread around. One of the other possibilities that
Liam, sorry to stop you. Could you actually share with people why that's important for those who might not have caught that the first time when Sarah was talking? Why it's important in terms of adding to that risk pool? Because,
yeah, the risk pool issue is one of the questions I want to raise about the whole idea of the public option or the Medicare buy-in, allowing people to buy into the system. I think one of the problems you end up with in a lot of these, and one of the real for crafting public policy that's not also going to screw things up economically, it's at the end of the day, there's a lot of like basic actuarial math that you're dealing with here. If a lot of people buy into Medicare and leave the private insurance models, then the costs have to go up because there's fewer people in there. One of the reasons that single payer is frequently attractive, at least in financial terms, and just for me, looking at the economics of it, is there's no way for any private insurance to compete with it because of the size of the risk pool that you'd end up with. The more people in a particular system paying in the insurance, the lower the costs are for everyone on it because you bring in tons of healthier people. That's the key issue with the age that Sarah was bringing up there. If you put more younger, healthier people into Medicare, then it helps to lower the costs in the system. But Medicare's costs are already a small fraction of the cost, like in terms of the administration, how the system actually works of private insurance. I mean, it's like, 4% or something like that goes to administration versus like 30, if I remember the numbers right. But it's a huge difference in terms of, the administrative costs for the insurance model overall, like what it actually costs to run the system. So I don't know, if you use the age graduated way, it makes a bit more sense because it gradually shifts the populations into risk pools, but at some point you still have a real problem. At some point, if you shift more people into Medicare, then the private insurance gets too expensive and doesn't make it. So I mean, I'm not sure I understand it as like, why take these steps in the first place? Why take the slower approach if you're always going to end up reaching a particular tipping point where it's very costly and there are downsides to it? And I think the public option models, the Medicare buy-ins, the Medicare for all who want it kind of idea are honestly the worst of both worlds in that, it allows tons of healthier people to jump out of the system, which is going to raise the cost in all these private insurance systems. And if we're not stepping in with the subsidies, and this is where, again, a lot of the European models appeal to me. If you're going to do private care, you have to step in with the subsidies and help people out. If we're not doing that, and we're also not regulating the companies. So, the government's going to subsidize this, right? Cool. I'm going to jack the prices way up. And yeah, that doesn't work either. It's just it creates a giant cash scam. So, I mean, the changes to the insurance model are going to be extremely complicated. You guys have mentioned several times, this is nerd night, so it's fine. We can get a little complicated here. But yeah, at the end of the day, the basic actuarial issues, the basic insurance issues are a complicated factor in any of things. We can talk about what is our ideal system till the cows come home. At the end of the day, there's still a numbers game that has to be dealt with.
Thank you, Liam. I love how you all are sharing viewpoints. Just well-rounded discussion that we're doing right now. Great. So given that, what can we learn from this past year in terms of the pandemic, in terms of access, coverage, in terms of getting care to people who need it, and they're not being able to receive it? What can we learn from this pandemic? What does it tell as a precautionary measure or something proactively that we could be doing? Let's start with, I'm curious to see on the care side, the provider side, a theme, but then let's start with but then I'm also curious about, since Sarah started off the last one, let's start with Athena on this one, the provider side.
Yeah, so lessons we can take from COVID-19.
Mhm.
So I think there's truth in what a lot of people are saying, which is the pandemic revealed many fault lines in American society, both in the healthcare system, the public health system, and in the economy as a whole. So I think there's a couple, being on the front lines and kind of taking care of patients with COVID in the hospital over the last year. I think here's some things that went really well. We learned quickly. The first time I was on service to the next month, each time I was on, we were getting better at treating people for COVID-19. So there was, we were able to deploy steroids, we were able to deploy remdesivir, we got better with supportive care. So hospitals worked, people worked really hard. The healthcare workforce is robust, although we're challenged by numbers at certain points. So that was a good thing. Bad thing, we have underinvested in public health, not healthcare, public health, for many, many, many years. It has been a falling share of healthcare expenditures, or overall health expenditures, for a really long time. And with COVID-19, we paid for it. We did not have the means to kind of distribute things like masks and vaccines, although we're doing much better now. We did not have the local connections to build trust to talk about physical distancing. And we didn't have the kind of overarching view to understand the challenges that people might face when it comes to competing sources of information, and maybe how, for a low-income worker who needs to take a bus to get a job, maybe it wasn't worth it to physically distance because that would mean wages that were lost. Those stories were swept up, I think, in this very healthcare-centric model, and we paid for not having good public health. So that didn't go so well. The other thing that I think did not go very well was the economic side. We quickly realized the types of trade-offs people were making between the health and the economy. The CARES Act was great. I think the stimulus is going to be great, but it just showed how much there was for American society to do for people who are down on their luck. Most of the patients I see are they're very poor. They face a great degree of structural racism, and the choices they make every day are hard. When I was seeing patients a year after the pandemic started, that patient was the son of someone who died of COVID and whose twin sister had died of COVID. There's tremendous amounts of loss. It also revealed a complete lack of mental health care to kind of catch people as they were dealing with grieving and so many of these other things that were happening in their communities. So lessons, there were some wins. The vaccine was a win. The clinical learning was a win. Telemedicine was a win. I think in places like Kaiser, they were able to actually expand mental health care to groups that weren't typically getting it before. So that was a good thing. But big gaps, lack of public health, a general lack of empathies for people's circumstances, lack of economic support, and kind of a more practical thing. We just don't have, when it comes to old drugs, kind of taking them off the shelf and trying to test them when it comes to new diseases, we were pretty slow in doing that. We didn't have big clinical trials testing things. We had little trials all over the place. And so that kind of clinical learning, an integrated system, a way that we could all get data and look at it together in a countrywide way, that was lacking too. So those are I'd say my overarching insights about COVID-19, at least to get this started.
That was a great doctor answer. I loved it. Okay, we'll go on with Sarah. Sarah.
So one of the things Athene said that stuck out to me was trust. And that, to me, as someone who's sort of involved in the policy components of public health, but also is representing in the women's health sphere, people who aren't necessarily always taken seriously when they walk in to go see a doctor. What really struck me was the lack of trust that the public health systems seem to have in patients. And so, we saw that with the early messaging around masks, where, we didn't want to tell people to wear masks because we didn't trust them not to hoard the high quality N95 masks that were needed by healthcare workers. So we told them not to wear masks. Well, that was a disaster that could potentially have been seen coming based on everything we knew about SARS and MERS and, And then hand washing, right? So fairly early on, we had a pretty good sense that the virus passed through air, could be now I can't say that word, aerosolized and passed that way. But there was sort of this fear that if we start talking about that, well, people will stop washing their hands. If we stop emphasizing transmission via objects, then people will stop washing their hands. And so now we have this really weird sort of cultural thing where you've got companies doing these massive sort of sanitation theater where they're spraying everything down, but packing people into office spaces with no masks. Maybe they're 6 feet apart, but they're in the same room for 8 hours at a time, breathing all the same air. It was sort of like a lack of trust from the public health. And, I know that this is a little bit disingenuous for me to get after them because I just spent how many minutes talking about people who believe in drinking the blood of baby, right? So I also have expressed a little bit of lack of trust in some parts of the populace, and I'm getting after public health folks. But, having had sort of more faith up front that if you gave people good information, that they would follow it, would have mitigated some of the lack of people following good information, right? And even in the sort of patient perspective, where we saw patients reporting long COVID symptoms, right? And they weren't being taken seriously. And that really strikes a nerve for us in the women's health world, because you do have all the time women walking into providers' offices with some pretty serious health problems that get dismissed out of hand. You're histrionic, you women, you're so emotional. So we kind of saw that play out, that same lack of trust in the in people reporting long COVID, and that all kind of builds, all that lack of trust from both sides, terrible messaging that was based on a lack of trust, and then people then feeling like they can't believe providers because providers weren't straight with them, or public health officials weren't straight with them from the get-go. We're sort of facing a massive, deeper, broader lack of trust in the public health system that I think is going to really reverberate for kind of a long time.
Public health, that seems to be critical right now in terms of messaging, being adequately prepared, and working hand in hand with our healthcare system and needs. Liam, do you have anything to add to that? What can we learn from this past year?
Yeah, there's several things I want to build on, but I think running from Sarah's comments about trust is a really good place to start, because it's not just trust in the public health system that's at fault here. Trust in governance is collapsing as a whole, and trust in society, and trust and faith in each other. We've seen over the last several decades a significant drop in the number of people polled who would be willing to marry someone of the other political party. We've gotten far more tribalistic. We don't talk to each other. And yeah, people are and Sarah's made this point as well about like the literally fake news that you can, any monkey with a keyboard can put some garbage on the internet. Someone's going to pass it around as true. People don't look at who's writing it. And we end up believing the most ridiculous things. And that has serious consequences, not just for public health, because people will believe the craziest ideas about how to take care of themselves and disbelieve genuinely good ideas like, I don't know, disinfect surfaces and wash hands and put on masks. I don't know, it's probably not without reason that Taiwan has had so few deaths from this, because they disinfect surfaces and people wear masks and they keep their distances. They didn't have to shut everything down because they took it seriously right away. They started talking about it. They were open about what they knew, and people said, oh, okay, good. I should wear a mask, right on. And they did it. We didn't do that. We sent tons of mixed messages, and that only contributes to an already deeply polarized and confused media space. I studied political rhetoric for a living, and this is a much bigger issue than just healthcare, our lack of trust in each other and in governance. And it's something we really need to find some way to deal with, because that COVID has really shown that this can hurt us. The combination of that lack of trust and understanding and the lack of universal health care. I mean, Public Citizen just had a big study out there that showed somewhere between 1/3 and 1/2 of the deaths we had, the fatalities we had from COVID would have been preventable if we'd had, better messaging on this and universal health care. I mean, because there's just tons of things we could have done and didn't do. Granted, some things we did all right, and as Sarah said, we were good at like vaccine distribution and whatnot here, but there's just a ton of things we didn't even bother trying contact tracing. Oh, you just got back from Wuhan? Cool. See you later, bye, and that was that. And it just slowly spread outward from there. I mean, I had to sit back and listen to my Congress member, my incumbent saying, oh yeah, it's totally cool for those flights to land on Ontario Airport. Let's just have them come through there. What? Yeah, I mean, at least they redirected it to an Air Force base, but then they just let everyone go, didn't bother taking any information, didn't check anything. We could have done better with this. And we just didn't. And I think a good part of the reason for that is still that lack of trust, that people didn't want to submit to any kind of like, health checks or quarantines or anything like that, because they didn't trust that there was a real problem. So, I would really like to see something done about that. Another one, though, that really stands out to me, and we might be able to talk about this a little later anyway, but Athene mentioned briefly mental health. And I really want to drive home a point about that, because we've had a lot of people that have been isolated for a year now, and people are climbing the walls. If you already had serious anxieties or depressions or whatever, and then you've been like isolating deliberately for long stretches at a time, we're not addressing that as a problem. And since mental health is not part of a universal healthcare package, it's not available to people. This again is one of the reasons and we can talk about this later too, I don't like the framing of Medicare for all, because it includes like dental, vision, mental health, things like that. I mean, it's a much bigger package than the current Medicare, like the brand that's currently out there. But since we don't have care for people, and I saw in the chat too, there was a reference to telecare with patients, being able to check in with them through Zoom or whatever. That's brilliant. If we had universal mental health care access and people could like connect with their therapist, and that was totally covered, we might have fewer problems than we're having now. I mean, I don't know. I'm just terrified that we're going to see, when we look back at the statistics over this, a massive spike in like suicides and suicide attempts that are going to be related to the COVID pandemic. And we won't find out until after the fact, once enough time has gone by to really process that stuff. I'm terrified of what we're going to learn, because we have not taken care of people.
Yeah, there's so many things we could be implementing in terms of what we've observed during the past year with the pandemic. And I know that the three of you have touched on some of those issues. Before we close out the night with a question at the end on how do we keep this conversation moving forward about healthcare policy, which I would love for each of you to close out on, I would like to open up the floor to Q&A. And so if you do have a question, go ahead and type it into the chat box, the chat window. I do have 3 questions that have already been submitted during this time of the panel. So if one of you, the panelists, Sarah, Liam, or Athene, if you feel like you want to go ahead and take the answer to the question that I'll be saying aloud, please feel free to let me know. Otherwise, I'll just go ahead and call on someone. Cool. All right. The first question is for QA, thoughts around making health insurance more like catastrophic coverage to make more affordable. Idea is from David Goldhill. And if you look in the chat window, a link was dropped to that if you wanted to click that. I believe it was a Forbes link. And it's Davis. I know Davis, great person. But yeah, Davis, feel free to drop in that link if you do have it. But who would like to take that one? How about making health insurance more like catastrophic coverage to make more affordable? I know who can definitely, let's do Liam on this one, since I don't see any voluntary raised hands.
I wanted to clarify. So by catastrophic coverage, you mean like after a certain expenditure you're making, then it kicks in and covers the rest? Because that's what they call my current plan, and I hate it. because every January my costs for everything shoot way up, and I'm paying several $100s for each prescription. And I've got an appointment coming up next week that's going to be another $430. I mean, everything just shoots way up, and then it finally kicks back in, and my prices go back to normal. But it's really hard to deal with. So if that's what you mean, then, but I'm not sure if that's what they mean by catastrophic coverage in here.
Got it. Yeah, and feel free to you can unmute yourself, Davis, if you wanted to clarify that question too, if you're still on. So Liam's question was, what do you mean by catastrophic? Just to be more accurate.
Can you hear me?
Yes, Davis, what's up?
Hi. So catastrophic coverage, the example David Goldhill gives, and he's a very interesting guy, is, for example, it's a really high deductible. We're talking like $10,000 to $25,000. So it's really about using insurance as a way of mitigating risk, right? So predictable things like getting a physical, predictable things like maybe even pregnancy. You really want to buy insurance to mitigate a cancer diagnosis. We need chemotherapy, which is $250,000, but you're willing to save up for other things, right? And that's what he means by that, by not making insurance truly as unpredictable coverage. So you don't buy car insurance because you want to change the tires or basic stuff. And so he's arguing that if we do it that way, people have more incentives to be healthier, right? If you have to plan for a few $1,000s for a pregnancy, but you're covered against emergency C-section, right? Would that be more affordable? So I sent the link on NPR, and I think he makes a good cases. I don't necessarily agree with him, but I just thought I'd ask, the question is, if we have to think about giving more coverage, what do we think about switching that model?
So I unmuted. That is, Davis, sort of what I thought you were referring to. I haven't read the NPR article, but I'll open it and save it for later. My sort of instinct is sort of referencing the study that Athene talked about earlier about what happened when you imposed cost sharing on people, and this expectation that they behave rationally, and they didn't. And I mean, that's sort of like when I try to think in my own life about the millions of things that I'm doing right now, getting my kids to remote learning, fighting with the PTO board, doing this, doing that, paying my bills, switching my insurance provider, switching my, my telecom provider. It's just extremely difficult for us to make very rational decisions across every sort of component of our life. And so what we do is we skimp on preventative care, right? We don't go in and get our annual checkup. Having gone through 3 pregnancies, I can tell you that it would be really difficult for most people to try and cover the costs of really good maternity care out of pocket. That would just, to save up, especially without some kind of universal basic income, to save up for those kind of expenses. But I mean, everything that, and again, I'm an evangelist for the ACA, so that's my bias coming into this. But the benefits of the ACA making preventative care, so contraception, making that cost-free or no copays. It doesn't count against, you don't have to pay a copay, and it doesn't count against your deductible. If you go in for an annual gynecological visit, if you go in for a breast exam, if you go in for these kind of preventative measures that that people pay a little bit up front and they save a lot on the back end, but in practice, they don't go in unless it's easy and affordable. And so I would be worried about moving to a model like that, about everything that we would hope people wouldn't cut out. And yet we know from having studied these kinds of issues that they absolutely will cut out. So that's sort of where I would come down on it. I would defer to others who want to jump in.
If you have an additional or contrasting view, Liam or Athene, please let me know. Otherwise, we're going to move on to the next question. The next question is, what are the panelists' thoughts on NPs and PAs to fill in the healthcare disparity, especially in a primary preventive care system? That one, anyone, any takers on that?
I love them. It's good.
Okay.
Yeah, I would say the same thing. I would say Athene probably has the best, comments on this, but I have no issues there. We do have a lot of shortfall in actual providers, so we should lean on what we have.
Okay.
Yeah, I was just going to say there's some great studies that looked at states that kind of basically increased scope of practice among PAs and others and showed that that was good for patients. So I think that's a good move. I know there's some physicians who don't agree, but I think we need to expand access, especially in rural areas. This is a good way to do it.
Great. The next question, German MD here. What is the most baffling to me in US? Okay, I get the clarification. German MD here. What is most baffling to me in US healthcare is the lack of transparency in costs and fees. Medical bills just don't translate into what was actually performed and seem completely arbitrary. Will an x-ray cost $50 or $700? You'll find out 4 weeks later. Will an ambulance cost $1,000 or $10,000? I added that part. So for that one, Leo, do you want to go ahead? Okay.
Oh, I was just gonna say, I've had those exact experiences where you don't really expect the massive bill. I mean, I was in a really bad car wreck a decade ago. The car was turned into a modern art piece, and I ended up getting crushed in and liver sliced open and whatever there. But the drive from where that collision happened to the hospital where I was treated was less than a mile. And the ambulance fee was thousands of dollars. And it's like, what? My insurance doesn't cover this? No, we don't cover that. Oh, that's nice to know. I mean, I think a lot of our healthcare, our private healthcare terms in this country are as confusing as the tax code to people. It's just a bunch of gibberish, and we just, oh, okay, no one gets it, and then you end up getting hit with massive bills later. So I share the frustration that this viewer is bringing up.
Thank you, Liam. The next question, thoughts on direct primary care? Thoughts on direct primary care? We'll go with Athene on this one.
Yeah, it's an interesting model, and basically it's a model where people pay a fixed fee, either it's monthly or annually. It's, kind of taking out the middleman to get primary care services, including doctor visits, getting labs, that kind of thing. The one concern I have, I think there's some adoption among wealthier folks with models like that. One concern I have is that will the monthly fees and annual fees price out lower income individuals? Even with the administrative burdens that are lower and the administrative costs that are lower, that might make those annual costs even cheaper. I think it might be a big ask for some of the sickest members of our society, who often are from the bottom of the income distribution. So scaling that up beyond folks that can afford it, I think it's going to be tough.
Thank you. And last question for the Q&As before we go back to the panelists with one last question, and I'll turn it back over to Sean. Any thoughts on unfunded Medicare liabilities of around $50 trillion forcing a crisis and real policy change? Let me read that again. Any thoughts that any of you have on unfunded Medicare liabilities of around $50 trillion forcing a crisis and real policy change?
I mean, the simple answer to that one is that it doesn't really exist. It's sort of like complaints about the national debt when people argue that we're all sort of on the hook for it, like we personally owe X amount of money, which is not actually true. It's literally impossible for the federal government to run out of money. State governments can run out of money. The federal government cannot. What it has to do is balance the production, because it's a currency issuer. It has to balance the issuance of currency and treasury bills with overall growth in the economy in order to manage inflation. As long as the economy is growing and you're managing it that way, then it's not really a problem. I mean, we, especially with Republican administrations spending on wars and everything else, we have spent ungodly sums of money since the 1980s, as debt, in deficit spending, and inflation is generally below the international targets in the US. It's not actually been a problem at all for us. So it's not, just this in itself, is not going to cause a problem, an unfunded liability, so to speak, because the money is always there if the government wants it. We just need sane fiscal policy in government to actually manage the economy as a whole to keep the inflation down.
Thank you. That's great that we had the politician do that one. All right, the last question, and this is for each of you. Feel free to close out. If you want to stick around and hang out, I think that's up to Sarah and Sean. But the last question is, what can we, the audience, do to keep the conversation about healthcare policy moving forward? And I know that organizing and pushing for change in policy and other areas can take different forms, whether it be sharing, just directly sharing with other people, whether it be joining action, petitioning certain representatives. But what is, given your work experience and the time you spent, what is an effective way to keep the conversation moving forward? Let's start with Liam, Sarah, and then Athene.
I would just say simply here, the single best thing we can really do is to have these conversations and to be coming to panels like this and, hearing the nerds all yammer on about it, and then talk to your neighbors, talk to your friends, because there's a ton of misinformation out there, and, we have to somehow get past that. And I think one of the things that can really, really help is to tune out all the partisan rhetoric on this, because everyone has an angle and they're only pushing their angle. And try to cut that out as much as you can. Honestly, it's frequently, and I have found this to be the case, it's honestly just a matter of framing the argument in the right way, discussing in the right way. I mean, Sarah could point out, I'm sure, as an ACA evangelist, how many people hated Obamacare but loved the ACA just because of the way and they're the same thing. But most voters don't know a lot about policy, and they're never going to know a lot about policy. But if we talk to our neighbors, that helps, that changes some of that, and we can talk about some of these issues. Yeah, okay, a single payer system might add $1,000 to your tax bill and then save you $10,000 that your employer is paying for your insurance. And that's part of your compensation package. You just got a raise. Like, whoa, it's a tax cut. Are you kidding? Because it kind of is. If we just have these conversations and talk about them more, I think it'll help a lot to get us out of this quagmire.
Thank you, Liam. Sarah.
So I absolutely agree with that. And, having these kinds of things, one of the reasons I was so sort of excited to join this is because I really think having healthcare conversations makes a big difference. It does filter up. For better or worse, Congress is a representative body. And so having an educated base of voters who are excited and passionate about an issue and want to get involved actually really does make a difference. We saw the passage of the ACA. No, it wasn't perfect. No, it wasn't everything we wanted, but it was a historic expansion of health insurance. We were able to defeat any attempt to repeal it, right? So we were able to build on it just now, literally in the Biden package that just passed, to make insurance more affordable for millions of people. So all along the way, this big groundswell of people caring about healthcare and talking to Congress about it actually has had huge victories. So even as we're getting kind of depressed sometimes about the barriers and everything else, we can look and say, wow, we really did make a big difference. And the other thing I'm going to say is that as the policy director for a national nonprofit, I strongly urge you all to donate to national nonprofits working on healthcare policy. And with that, I'll turn it back.
Thank you, Sarah. All right, and Athene, closing out.
I agree with all of that. I think the one additional thing I'd add is, share some of the stories that you put in the chat with other people. I think those conversations build empathy. They kind of clarify what the challenges are in the healthcare system. And I think that builds a lot of motivation. Even if we don't agree on the solution, if we can all agree that there's a real problem and that there's many Americans that are hurting out there, I think that goes a long way. Just as an academic, I might say the stories that come to me are things that I try to take to the data and understand if they're happening all over the country. So share those with folks like me too, who try to build these stories by looking at large data sets, and share them with your colleagues, share them with your friends. And it's hard to advise a group that's coming to a health policy nerd night on a Sunday evening. I mean, you're already doing the thing that we're asking you to do, but please keep that momentum going.
Great. Thank you so much, Liam, Sarah, Athene, for taking the time to share your views and talk and really contribute to pushing the conversation forward in that. And so now I'll just hand it over to Sarah or Sean. And thank you everyone for tuning in.
Thank you to all of our wonderful panelists here for this call. We greatly appreciate their wisdom and insights, and as well as all of these attendees for sharing their stories and their understanding of the issues at large. We just wanted to tease one other event too. Sarah, I don't know if you had more details on that.
Well, you're going to be intentionally sneaky because we want to keep you all in the loop. But next month, we'll be having a Policy Nerd Night panel series on HR1, the For the People Act. And it will be a joint discussion with another, with a national nonprofit, as a matter of fact. More details coming in a matter of days, probably. So subscribe to our Slack channel. Hit us up on Instagram. We're going to be posting all about that in the next week or two. It'll be a great panel and a really relevant one with timing and everything. That's all I had to say. Sean, back to you.
Yeah, and if you wanted to get involved or just hear about more of our events, there's our Slack link, which is posted to the channel. And if you want to catch the recording of this, you should visit Liam's YouTube channel anyway. I believe it's been posted in the chat. So once again, thank you so much to all of our panelists, Athene, Liam, Sarah, and David. Great, excellent people. Thank you for this night.
Absolutely incredible. Thank you all so much again. Have a great rest of your night. Thank you.
Hey, thanks for having us. Take care.
Bye, everyone.
Bye.